Good afternoon, everybody. My name is Sharon Byron from TruCode, and I want to thank you for joining today's webinar, Outpatient Clinical Documentation Improvement, a Practical Approach. I'm thrilled to welcome Dr. John Ellion back this year to present another webinar for TruCode. If you've ever had the opportunity to listen to Dr. Ellion present, you know you're in for a fabulous webinar. He has a unique way of presenting information that keeps his audience interested and engaged, so we're in for a treat this afternoon. Just a little about Dr. Ellion. He is a graduate of Brown University, trained in internal medicine at the University of Wisconsin, and in cardiology at Duke University. He's currently an associate professor of medicine at Brown University, and he still practices cardiology part-time at the Miriam Hospital in Providence, Rhode Island. And he served on several hospital finance committees and boards. In 1994, he founded HeartLab, the world's leading designer and supplier of digital image and information networks for cardiology. He's chaired the Cardiology Working Group for the DICOM standard and wrote and coordinated the landmark multi-vendor demonstration of the DICOM standard in cardiology. Dr. Ellion is the founder and CEO of ChartWise Medical Systems, whose premier product, ChartWise 2.0, is a comprehensive system to support clinical documentation. And it's been ranked class category leader in CDI for 3 years in a row. Before I hand it over to Dr. Ellion, I want to review a few housekeeping rules to make sure we have a successful webinar. First, everybody is in listen-only mode, which means you'll need to use your control panel to communicate. You can find your control panel on the right-hand side of your screen. If you need to minimize it to see the screen better, you can collapse and expand it by clicking on the little red box with the arrow. If you want to ask a question, and we do encourage questions, you can do that in the questions section of the control panel, and that's towards the bottom. We also have Karen Scott from TruCode on the line, and she's going to help field questions for Dr. Ellion. So to ask a question, just click on the little plus button, and that'll open up a text box. You can type your question in the box, and then we'll pause periodically. Karen will read a question, and we'll try to get to as many questions as we can. I just want to point out also there are handouts for today's presentation. Those can be accessed in the handouts section of the control panel. And finally, and most importantly, you will receive CEUs for attending this webinar. Tomorrow morning, we'll be sending out an email to everybody who's registered. It'll contain a link to the recording. It will have a brief webinar evaluation. Once you complete that evaluation, you'll be able to download your CEU certificate. And if you have any questions or any problems, you can respond to your email or email me directly, cbyron@trucode.com, and we'll make sure we get your CEU certificate taken care of. So with that, I'm going to hand it over to Dr. Ellion. Thank you, everyone.
Thanks, Sharon. I see we've got a whole bunch of folks who've joined, and that's great. Normally, I like to kind of poll an audience and find out who's there, who's in CDI, who's in coding, who's in management, and I purposely didn't put a electronic poll here because we spent all of our time doing that. But I'm going to make the assumption that we've got some of all of those people, and if there's some people doing CDI or assisting with CDI, that some of you are starting to either hear the questions about outpatient or you're actually launching on that adventure. Or if you're like me, you've been to a bunch of webinars or workshops or lectures about outpatient CDI, and you leave the room scratching your head trying to figure out what all of that means. So that background was kind of the motivation for putting this talk together, and I'm hoping that my slide works is what I'm hoping. There we go. So there's some learning objectives, as there need to be when we're offering the CEUs, but what you'll hear me talking about is taking this huge quagmire of outpatient CDI and try and reduce it to 5 basic components and learn how to grow an outpatient program from your experience on inpatient, how to measure things, how to describe the value of risk adjustment factors in all of this, and then how to put together some metrics and reports. And I can't emphasize strongly enough the interactive nature of what we'd really like to do. So please, even comments, questions, feel free to go ahead and send those in. I'm sure I'm going to have something to annoy everybody that's on the call. because I want to be a little provocative and I want to poke us a little bit and push us and to learn a little bit. Now, Sharon basically gave you my background, but just to highlight one or two things. My first paying job in hospital software was the summer of 1969. I suspect many of you on the call were not born yet in 1969. So I've been doing this for quite some time and basically started a parallel career in computer science and medical science and got my MD degree and then cardiology training. And I'm often reminded of that advertisement for the hair club for men where the guy says, I'm not just the president, I'm also a customer. I'm not just somebody who's in the commercial realm with the developing the systems for assisting with clinical documentation improvement, but I attend clinically and I take care of patients on the intensive care unit, and even I get queries. So that's kind of fun to be on both sides of things. And I start almost every talk that I give with these next slides or two, because it's so important. If you are just trying to get improved reimbursement, then you're going to miss a high-quality medical record. But if you're pursuing the high-quality medical record, the proper reimbursement will follow. I didn't say the increased reimbursement. I said the proper reimbursement will follow. And it's about quality. It's not just about reimbursement, because after all, accurate and coded data is essential for the things that are listed here. And this is an ever-changing list. Seems every week there's something new that's capturing the headlines in the newspaper or in the online discussions. But it all requires, to get the statistics and data that you need, everything requires accurate coded data. And to get that, clinical documentation is the cornerstone for the accurate coding. So I used to, in my talks, ask the audience how many people were trained this way, which is to find a major complication and then move on. And I was stunned that nobody raised their hand, until I learned I was asking the question wrong. And so what I now ask an audience is, how many people know somebody who was trained this way? And lots of hands go up. So it's very important, and more important every week, to not fall into this trap, because if you're just going after the reimbursements and the MCCs, you're going to miss the fact that our reimbursements are changing. And I'm going to go into some alternate payment models and what that means, and as we move away from fee for service, how does that impact our thinking? And each week, this statement just seems more and more true. So with that brief background, I want to start talking about outpatient CDI. And sometimes I feel like one of these physicians who's going, give me a break. I'm having enough trouble struggling with answering your queries on the inpatient side. Now you want me to do it for outpatients as well? What is it that you really want me to do? And if you've been to any workshop on outpatient CDI, if you've been to any lecture, everybody seems to have a slide that talks about outpatient CDI is not the same as inpatient CDI. And I've picked out a couple of the highlights of how they might be different. For example, different coding systems. Inpatient, we obviously use ICD-10, both the CM, which is the clinical modifications or the diagnosis codes, and the PCS, which is the procedure codes. But in the outpatient arena, we're using CPTs, HCPCS, APC grouping, and so on. So there's different coding systems. And inpatient, while there may be medical floors, surgical floors, ICUs, step-down units, and a variety, they're fairly uniform in the way that we approach inpatient CDI, whereas in the outpatient, there's a whole variety of clinic types. The emergency department might be inpatient, might be outpatient, depending on whether the patient got admitted or not and how you treat it. So there's a lot more venues to account for outpatient, and there's potentially a different set of coders and coder requirements. And on the inpatient side, we tend to do CDI during the stay, but that's really hard in an outpatient visit where you're actually doing it before and after. So you're doing a pre-review and then a post-review. And the outpatient setting has very specific and unique requirements for annual visits. So we'll go over this, but basically on January 1st, things tend to reset, and you've got to revisit the things from last year and document again whether you're going to be monitoring, evaluating, assessing, or treating those. And so there's some annual requirements. And then inpatient is pretty obvious what the encounter is. The patient gets admitted, some things happen, and then they get discharged. So you know what the encounter is. But in the outpatient setting, things may be set over multiple visits. For example, the simplest thing is you come have some lab work drawn on Tuesday, and then you come back and see the doc on Thursday. That would be one potential scenario. And there are some clinics, for example, a wound care clinic, where actually you can come for many episodes of care that are actually rolled into one encounter and billed as one encounter, even though you came to the building on multiple days. That's something that just doesn't exist on the inpatient side. So this is what you typically see as the very first slide in any workshop on outpatient CDI. And then if you're at a 8-hour workshop, the next 7 hours are going over these stakeholders. And I'm not going to list these off and read them to you. And by the way, many of these slides are here so that they are in your handout. They're not here for me to read them to you. I'm assuming you can all read, and I won't sit and read them line by line. This is an example of a slide I'm not going to read to you, but all of these folks in some manner have some stake. E&M coding is my least favorite. I got my MD degree in 1975. I've been doing E&M coding ever since, and I'm still pretty lousy at it. I tend to be an under-coder for myself, but we'll talk about that another day. But physicians' offices, emergency departments, urgent care, all over the board, each of these, and many of the workshops would have you believe that you'll therefore need 25 different outpatient CDI endeavors, one for each category of thing that's here. So I, like many people, left some workshops and some seminars and lectures very puzzled, because talking about how different outpatient is than inpatient didn't lead me to any conclusion, didn't help me figure out what it was that I wanted to do. So I would ask the question, well, how did this workshop or experience help me to plan implementation of an outpatient program? And is it helpful to say that outpatient is so different than inpatient? I don't know about you. I hope there's some of you on the webinar today that share that confusion and trying to figure out what to do. And it certainly didn't help me to think about that way. So I went off in the corner, having read everything I could, attended everything I could. I went off in the corner and contemplated my navel for a while, and started after a short time to see some patterns start to fall together of some similarities between inpatient and outpatient, which led me to this particular talk, which I hope by the end you're given some practical approaches of where to start. And sometimes it's more helpful to look at similarities than it is differences. And that's kind of the premise for what I want to talk about. So wherever you are, inpatient, outpatient, there's evolving definitions of quality documentation. I tried to figure out who I stole this from. Because this appears very commonly now, and I don't think the original author necessarily annotated or gave the credit. I have wordsmithed it a little bit, but you're going to see this more and more, that these are the criteria, these are the characteristics of high quality documentation. Another example of where I'm not going to read this all to you. But we want things that are very timely and clear and very complete with a high level of not just precision, but actually accuracy. Again, another day's discussion, and maybe I should change the slide to be accurate. Precise, you could miss the mark, but if you miss your mark exactly the same way every time, then you're precise, but not accurate. So this is our goal. This is where we want to get to. So I want to now just give you a completely different view of outpatient CDI, as Monty Python would say, and now for something completely different. Inpatient CDI and outpatient CDI actually share these 5 common factors or approaches. So I am now personally thinking of outpatient CDI in these terms and seeing how I can build on inpatient CDI knowledge, software tools, and technology to extend our efforts into the outpatient arena. But in both venues, you're trying to find the patients of interest. You need some help with reviewing the chart. You need to query the provider to get some more accurate and complete information. You need some way to track appropriate metrics and key performance indicators. A KPI is a key performance indicator, and you need comprehensive reporting. And you'll need these whether you're inpatient or outpatient. So I want to, for this talk, focus on these. I'm going to emphasize number 4, disproportionately long amount of time I'm going to spend on the KPIs and how it is we can measure what we're doing. So let's just start with how do you find patients of interest. Finding patients when they're inpatient is actually trivially easy. Many years ago, people used to go to the electronic medical records, or if you didn't have a full EMR, you at least had an admission and system, and you could get a census printout, and you'd review that in the morning and figure out who you were going to go see, whose chart you were going to go see for clinical documentation improvement. And that's evolved to where electronically we rely heavily on the HL7 ADT message. Now, HL7 stands for Health Level 7. It is not a version number. There was no HL6. There won't be an HL8. It's a hierarchy, and this is the highest level of specificity for messages that are sent electronically around your hospital. Your hospital has worked very hard to get an ecosystem where the various systems talk to each other. HL7 is the way they are transmitted. And ADT is pretty uniformly implemented. So if I'm trying to get an inpatient census, I just have to listen in on the ADT traffic, and I've got it. Ironically, for outpatient, trying to get the census, which is so easy on the inpatient side, what should be trivial turns out to be very difficult on the outpatient side. Now, there are times that an HL7 message is going to be helpful, the ADT can have some outpatient information, but unfortunately that may have too much information in it. For example, if I need to go for an echocardiogram, I will go to the hospital, they send me to the admissions desk, I sign in there, and then they send me down to the echo lab to get my echocardiogram done, and then I go home. Well, that generated an HL7 ADT message, but I never got seen in a clinic. I was just there to have a test done. So ADT is not all that helpful. There is a very cool message called SIU, Scheduling Information Unsolicited, meaning, hey, I know nobody asked for this, but let me just tell you, Joe Smith is going to be seen Tuesday afternoon in the oncology clinic. So SIUs, when they are used, are perfect. They're kind of the outpatient equivalent, if you will, of the ADT. They are not reliably implemented. They're not uniformly implemented. And many people say that HL7 is not a standard. It's just a suggestion. So there's still a lot of variability. And while I would normally shy away from trying to do custom interfaces, there's a lot of nice practice management systems that are managing all of the details of your practice in an outpatient setting. And that's the most reliable source for the schedule. So that is proving to be one of the more difficult things to get electronically. It's still very easy to print out, for example, the third bullet there. If you want to get a printout of all the patients who are going to see Dr. Ellian in Tuesday afternoon clinic in the East Greenwich location, that's pretty easy to get. You could also get a list for all of the providers who are there at that time slot in that location. So the paper printouts are actually fairly easy, but electronically, that remains very difficult. So that's about as much as I want to say on finding the patients. It remains one of the difficult stumbling blocks for implementing an outpatient program. Now, it's nice to have something that is helping you with the review process, and I'm not going to linger on this, but I'm just going to give you an example or two. I work in the field of artificial intelligence, and as you know, that everywhere you turn these days, it's AI in medicine, AI here, AI there. And unfortunately, it's already being overused as a term. And I looked it up. The official definition is just anything that helps the computer mimic some type of human behavior. That's awfully broad, and I take a much narrower view of that. And my training and background is in expert systems. And I guess that makes sense because I am often called upon to be the expert consultant in the hospital. So I am functioning as an expert system in my daily job. But I look to computer software and what's called a rules engine to actually learn some new stuff. And basically, a rules engine takes facts that you give it, and from that tries to draw new conclusions. That's called forward chaining. And just for the masochistic who are interested in learning these things, backward chaining would be, in order to reach this conclusion, what data do I need? So we're doing forward chaining, and a rule system keeps the knowledge separate from the computer software because we're in a rapidly changing field and you can't keep changing computer programs every week, whereas when you have the knowledge in a separate library, you can change that and it can process vast amounts of information very rapidly. And a rules engine can be is very well established, and the one I have the most experience with is actually taken from the Johnson Space Center's Artificial Intelligence Group, and their rules engine is rock solid and extremely fast. And this would just be an overview. Now, this is from PSI, Patient Safety Indicators. It's a more specific example. It's parallel to CDI, but it takes patient data and knowledge of the 4,800 pages of PSI specifications, churns all those together and can make some suggestions and advice and tell you what PSIs for which ones the patient is at risk and for which ones they're excluded. And the PSI rules would look something like this. Actually, this is not a mock-up of a slide. This is taken from an actual PDF printout of some actual rules, and it just shows you that tells you how things are included and excluded. I don't want to get too sidetracked into the artificial intelligence, but it's just an example of having something that is helping you with your review. And computer-assisted coding is very interesting. It tends to happen after discharge rather than concurrently during the admission, and it is very good at finding what is on the chart, whereas in the CDI world, we're trying to find what is not yet on the chart. So with this type of approach to artificial intelligence, it's worked very well in the CDI world. This is very challenging, having appropriate and conformant queries. Let me just give you an example of the challenge. On the inpatient side, the ethical standards and the practice guidelines that have been established say you can only talk about information that is present during this encounter, meaning this admission. Well, as we talked about, that's easy on the inpatient side, but what are you going to do on the outpatient side when they came in on Tuesday for lab work and you're seeing them on Thursday? So the Association of Clinical Documentation Improvement Specialists has put out a white paper in which they're now talking about queries in the outpatient arena, and they feel indeed that it is relevant and appropriate to be able to bring in an encounter that isn't the face-to-face encounter. But there's a lot of other things that we're going to need to do. And what I've done is just put together 4 or 5 examples of some of the queries that I tried to pick ones that are a little bit different from the kind of thing that we'd be doing on the inpatient side. So in the outpatient arena, I might see somebody for a cardiology follow-up this year, but I haven't yet addressed something that is on the chart. And the example is I'm seeing a 68-year-old man, and he's had prostate cancer with a prostatectomy, but there's no status or plan or monitoring for the prostate-specific antigen documented. Now, I have to be careful because if I'm seeing somebody for a follow-up of an MI and I order a PSA, that will actually be declined because a PSA is not an appropriate test to do as an MI follow-up. So I need to document that one of the reasons for this visit was a health assessment, and then I can order that, so there's a medical necessity factor. But normally I would just say, well, status post prostatectomy, status post prostate CA. But things that are recurring every year, you've got to reassess that and bring that back in. Now, I'm probably not going to comment on the tonsillectomy and adenoidectomy or TNA that the patient had as an 8-year-old. I might comment on the splenectomy that they had 20 years ago because that has implications for immunizations. And certainly if there's recent breast cancer or prostate cancer, you do want to mention that periodically. And that is less important. Status post prostatectomy is not something that gets you an inpatient reimbursement or affects the DRG, but is something important on the outpatient side. You have to make sure that you're addressing things or things that might be addressed that aren't documented. So this is an example of a patient where the height and weight are documented. There's a BMI, and I talked about the need for weight loss, but I didn't document it. So I am addressing it, but I need to be careful to document it. Another example would be that there's some things that are suggested but not yet documented. So, for example, a calcified hilar node on chest X-ray, it's there and it suggests diagnosis. And by the way, I cheated by making it calcified hilar node. That's a little more likely to have some significance. For example, burned out tuberculosis might show up that way. So that's something that there's a finding with a possible diagnosis not yet documented. Well, that one's pretty similar to what we see on an inpatient side as well, so not that unique. And I'm just glancing over. I noticed that somebody said that their sound is cutting in and out. Sharon, Karen, are you hearing me okay, or am I cutting out here?
I'm hearing you fine. I'm not sure. I'm listening to the audio over the phone, so that might be an option if you're connected over the through the internet. There might be spotty audio if your connection is not good. You might want to try connecting through the phone line.
Okay. And I'm going to keep going. Compliance, and that is with the forms that are in a chart, one of the things that's asked in a periodic visit, did you counsel the patient about seatbelt usage, sunscreen, and smoking cessation? And it's all too easy to check those off when, in fact, you didn't do that. So you always have to be careful about things like that, but possibly more so recently. And then my least favorite topic on the planet, which is clinical validation and making sure that the diagnosis is indeed present. For example, there might be something mentioned about coronary artery disease. Just because a EKG showed minimal inferior Q waves, that could be a normal finding. The EKG might say, consider old inferior myocardial infarction, and somebody slaps a designation of CAD on the chart, and that gets carried forward, and one needs to be careful about that. So clinical validation, and by the way, I'm gonna pause after this slide, so Karen, see if you've got something ready for me. But on the clinical validation side, the reason this is my least favorite is payers are now challenging clinical validation, and they need to have some criteria by which they're going to challenge, and it becomes one of those games where, you're not following the rules, but we're not going to tell you what the rules are, doctor. It used to be if the doctor said it, that's enough to carry the day, but now the payers are getting fussier and fussier and challenging the fact that you got to prove to me what it is that you're saying is actually true. So, for example, I'm going to pick a simple myocardial infarction. I might choose the 3 ancient time-honored axes and say that there's a history, patient had chest pain, there's EKG findings, they have inferior ST elevation, and they have enzymatic markers. They have an elevated CPK, they have an elevated troponin. And with those 3, I could defend that they had an acute myocardial infarction. But there are no published standards for the clinical validation. Now, many of you may be familiar with a book called Guide to Clinical Validation, Documentation, and Coding. It is a very comprehensive listing of at least the top 50, but their clinical validation lists, quote unquote, are a pretty exhaustive list of the kinds of abnormal findings that are present in the disease, and they don't really constitute criteria which says on what basis do you need to make this diagnosis. So this is why it's not very favored of mine. The payers are challenging, and it's just important. There is no definitive list. There is no gold standard. And I like to think of it as the opposite of CDI. CDI, we say, hey, doctor, the chart shows these things. What could it be? And clinical validation says, hey, doctor, you said it was this. What's your validation? What's your proof that that's actually what's going on? So we're going to see a bunch more. So I'm going to just pause. And Karen, you got any questions you want to throw my way?
Sure, we have a couple that you won't want to take right now. One of them is the role of coders changing that now that we need to question clinical validation prior to coding?
Short answer is yes. Because, well, first, the role of coders, I think, has been changing and evolving in the last 5 or 10 years, far beyond that. But it is putting us all in that awkward position where, yeah, I think the coder should be challenging that, but again, on what basis? And you want to tick off a doctor, just have somebody who doesn't have the letters MD after the name question their diagnosis, and that's very upsetting. But I want us all to be upset at the right thing and not at each other. But this is an evolving field, and I think the payers may be right in questioning this, but we all need to work together. Coders need to catch it. Anywhere where I've made a statement about a diagnosis, but I haven't presented the supporting data. And I'll just mention in another talk I do on CDI, I train doctors to be aware of at least 3 tiny little expressions. One is due to. If you tell me a finding patient has a GI bleed, tell me what is due to. Tell me that it's a bleeding GI ulcer. So due to is important. The flip side is manifested by. Patient has complicated diabetes manifested by the ophthalmopathy, the nephropathy, and so on. And the third one for medical necessity is indications include. I'm sending a patient for a permanent pacemaker, indications include such and such. So this is where, and with a simple phrase like that, when I make a diagnostic statement, I can put the supporting data right there and really make it very clear. And I think a coder has every right to challenge. As people I'm sure on this call know better than I, there's some coding clinics that have muddied the waters a little bit about if the doctor says it, can you just go ahead and code it? I think the coding clinics are the low bar, not the high bar. And our goal should not just be to meet the minimal standards set by coding clinics, but we can exceed them. So if you're uncertain, then absolutely you should challenge that. So short answer, yeah, I think coders' roles are changing.
Thank you on that. Someone asked if we could repeat the name of the book you were just talking about.
Sure. I didn't want to mention the vendor, but I have to. It's by Optum, so it's optumcoding.com, and it's called The Guide to Clinical Validation, Documentation, and Coding.
Okay,
and if you're familiar with Optum guides, there are various guides. The plot's not too good, and the characters are not well developed, but it's very, very complete. It just increases my frustration because it is absolutely correct. It's a wonderful book that is very thorough and very correct in showing all of the factors that would go into the clinical validation, but nowhere have I found yet somebody who's bold enough to step up to the plate and said, here's the 5 criteria that have to be met for this diagnosis. Those do exist in medicine for certain categories. I'm just going to pick one that's based on a TV ad, but psoriatic arthritis, there is no definitive test for psoriatic arthritis. You have some clinical markers that you might want to say if the patient, by the way, they can have the arthritis without psoriasis on the skin. They can have the skin lesions without the bone lesions, and there's nothing definitive that says it's psoriatic versus rheumatoid. So there is no specific marker. So there's one, and there are many, 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 many in medicine that, well, we think this is what it is, but you don't have an absolute marker for that. So I'm hoping in a year or two I'll be able to say something different about clinical validation, but we're still struggling.
Great. And we had one more on HCCs, but I think you're going to be talking about that later, so we might want to wait on that one. Okay. Then we'll just let you go ahead and get started again.
Very good. So with that introduction, let's talk about KPIs and metrics, and we are definitely getting into HCCs and RAF scores, risk-adjusted factors. I'm pretty big on KPIs. Now, another brief diversion, there's a phenomenon called Taylorisms. I don't remember Taylor's last name, but he was very big in early manufacturing days in the United States, and his premise was if you can measure it, you can improve it. So if you're talking about a factory assembly line and you can measure everything, that each thing that you can measure, you've got some opportunity to improve it. A Taylorism is an assumption of the opposite, that if you've measured it, you are improving it. And way too many people are out there measuring things without it really being something that they're going to work on or improve. My favorite KPI, well, not my favorite, but my favorite example is if I want to improve the customer experience in the drive-through lane at the local McDonald's, I would measure the amount of time that they were in the drive-through lane. It's measurable. It does reflect the underlying process that I'm trying to improve, and I can impact it. So it meets the criteria for a good KPI. But you want something that actually does reflect how the organization is achieving your business objective. And it's only as good as the action that inspires. Now, I think everybody's heard of SMART, that SMART abbreviation. The words that go with it are often used differently. I've listed some of the more popular words that go with each letter of the acronym. But you need to know exactly what you want to do. You have to know when you've reached it. You have to be able to impact it. Why measure something that you can't change? And it has to fit into a big picture and know exactly what you want and when you want it. I'm on the Quality Oversight Committee at my hospital. They measured a whole bunch of things. They presented us with this dashboard, and I noticed the doctors' patient satisfaction with their physicians was in red. And I said, well, which doctors? We don't know. Well, what are they doing wrong? We don't know. Well, what are you doing to improve it? We don't know. That's no longer a key performance indicator. And by the way, that's all been changed and improved, not just because of me, but other people knew that that was a problem. So be careful that you do meet these criteria when picking your KPI. So this one is a 2-hour talk. I've got to get through it in just 30 seconds on the slide. On the inpatient side, we developed methodology that was initially targeting Medicare patients, but we found it applies to everybody. If you measure the DRG weight, that's a pretty good reflection of how complete your inpatient documentation is. But the methodology, the queries, everything else works just as well for the private payers. On the outpatient side, we're trying to focus on chronic conditions. Inpatient is acute, outpatient is chronic. And similarly, if you focus on a risk-adjusted score, which really applies to Medicare Advantage and some other scores, some other paying plans, but if you use that, that's a really good measure of the completeness of your documentation of chronic conditions. So I want to talk about risk-adjusted scores because that is what I am proposing as a superlative KPI. It happens that outpatient visits, while they may be coded and paid on CPT and HCPCS, the RAF scores are computed from ICD-10 codes. And guess what? Our CDI staff already knows about ICD-10, and they may not know about CPT and HCPCS codes. So it's a natural when you're taking your CDI staff from the inpatient and extending them into the outpatient arena. And now I'm going to refer you to these slides in your handouts. I was just thrilled to be at the American College of Cardiology meetings recently and heard some of the best talks and saw the best slides on alternate payment plans. And these next few slides are borrowed from Kathleen Biga and are presented with her permission. And it helps explain how we are moving from fee-for-service to the alternate payment models. I think everybody on the call has heard this, that we're moving away from fee-for-service. Now, this is a fictional graph. This is make-believe data. But it does show that let's see where we are, 2018, that we've moved away from fee-for-service that was so prevalent in 2008, where 85% of reimbursements were based on fee-for-service, and in 2018 we're down around 30%, and that's going to be falling, whereas these alternate payment models are on the rise. So in 2008, we had fee-for-service, and there was very little assessment of value that was going on, and not too many hospitals are like that anymore. We then kind of said, well, we'll do fee-for-service, but now we're going to start doing assessment of quality. And from there, we said, well, now we're going to bring in these alternate payment models, but boy, that fee-for-service, that's so well established. We're going to keep that architecture, but we're going to start on the alternate payment models, and now you get into the alphabet soup with the affordable accountable care organizations, ACO, the bundled payments, et cetera. And where we are moving to is we're going to change the underlying architecture now and abandon the fee-for-service. And this is coming along in the next few years, and we're already seeing it in terms of the next generation ACOs. And I warned you about the acronyms and the alphabet soup, the CPCs and the CPC pluses and so on. So this is where healthcare is going. This shouldn't be a surprise to anybody. But like I said, if you just spend a couple of minutes with these slides and the handouts, I think it'll really be helpful to you to understand where things are going. And now this is the payoff. This is why I think the risk adjustment is so important, because almost all of the new payment models are based on risk. How sick is my patient? And actually the risk score means two different things. It means how sick is my patient, but it also means how much resources am I going to have to expend to care for this patient? So if you're starting in this arena and you're going into outpatient, or if you're doing any new programs, if you start anywhere, start with the risk scores. So the next few slides, I'm going to skip over some of this. Again, they're here so that you're in your handout. If you're really having insomnia and having difficulty falling asleep, then you can read up on the history of HCCs and the hierarchical condition categories and understand that. I will go into it in a little more detail. And early on, when I was struggling with risk adjustment and trying to figure it out, this particular diagram came to mind, and it helped me. This is one that I just made up. We all know this. You make a list of diagnoses and procedures, by the way. It goes into a DRG grouper, and out comes a single DRG. That DRG is associated with a weight. That weight does reflect the underlying resources needed to care for that particular patient. So that can be used as some measure of the completeness of your inpatient documentation, as we talked about. On the outpatient side, there is an equivalent that you feed your diagnoses to a RAF, risk adjustment factor calculator. It comes out actually with condition categories. Nobody talks about that for two reasons. It's not really interesting just yet, and CCs gets confused with CDI work and complications and comorbidities. But actually, it does come up with a list of condition categories, puts them into a hierarchy, and I find that this is what a lot of people are concerned about, is their HCCs. And if I can be controversial for a minute, I'll say I'm not interested in HCCs. I'm not interested that we took it from 2 HCCs to 3 HCCs. I'm not even interested in what they are. What I'm interested in is the RAF score that results. So the HCCs are a vital intermediate step. They are interesting because they get me to the RAF score. That score tells me how I'm going to be reimbursed. That score tells me how sick the patient is. That patient tells me how much resources are expected to be expended in caring for the patient. So just a little bit about HCCs. When you add up, if you have several different hierarchical condition categories, they do add up, and you can take it from multiple different places, inpatient, outpatient, physician settings, and last year's performance dictates this year's reimbursement. I'm going to say that a little differently. Towards the end of this calendar year, we're going to be faced with your 2018 performance is going to drive your 2019 reimbursement, but it's awfully tough to get data back quickly from Medicare and be in a position to know what kind of plans you should be putting together for next year. So the HCCs are really driven heavily by the chronic diseases, and I'm often surprised at the things that are near and dear to my heart for inpatient don't necessarily impact the outpatient as much, and vice versa. So again, these are in your handout. I just want to underscore that the Medicare CMS HCCs do not include drugs. There's a separate HCC model for the drugs, whereas Health and Human Services that also has risk plans, the drugs are included. So routinely, the HHS risk scores are going to be higher than the CMS risk scores for that reason, because it includes the drugs. So there's a couple of things we need to keep in mind, and folks who have started with outpatient CDI often start with this type of approach, going after the HCCs, which is a good thing, and it has to be documented based on a face-to-face encounter. Patients should be seen annually, and I don't know how we got to an acronym of MEAT, M-E-A-T, but each condition you have to document if it's being monitored, evaluated, assessed, or treated. If I had been asked, I probably would have said team instead of MEAT, but actually surprised nobody asked me. But you've got to document all of this at each encounter, and confirm all the confirmed conditions should be in the documentation with some statement of the significance of abnormal findings. So not all of that is unique to outpatient, but the fact that you've got to reevaluate this every year is important. This one I'm not going to linger on because I'm keeping an eye on the clock here, and we've got a lot to get through. So this is in your handouts and is worth spending a little bit of time studying. Now, I just want to give an example that's kind of fun, and if you do anything with severity of illness and risk of mortality, you already can guess where I'm going to be going on this. This is a patient with a laparoscopic cholecystectomy, otherwise known as a lap chole. They came in with an acute abdomen, a painful abdomen. It turned out to be cholecystitis. They went for a lap chole, and you queried because they had some renal insufficiency, but the doc hasn't answered yet. And post-op, they developed acute on chronic systolic congestive heart failure, which, of course, the cardiologist documented thoroughly. And this is the profile. You're going to get reimbursed $18,000. There is an expected length of stay of 5.4 days. The RAF score is 6.23, et cetera. But if you queried for the renal failure, you are not going to impact the reimbursement. You are not going to impact the GLOS or the relative weight because you already had an MCC, and you can't get any better than an MCC. So you had a diagnosis, a procedure, and an MCC. You got the maximum money. But look what happens when we add the chronic kidney disease. You queried for that. The doctor answered, and now you know that there is stage 4 kidney disease. That moves the needle on the RAF score. Severity of illness, risk of mortality tend to do the same thing, where there's a lot of things that can move the needle on the severity of illness that didn't change the reimbursement. Now, I just want to remind us one or two things about the RAF, and then I'm going to share some fun data where I actually analyzed hundreds of thousands of admissions to see what RAF scores were doing. The number of HCCs is on the left, and an arbitrary RAF score. I didn't put any numbers there, but a RAF score is on the right. And this shows that this patient started off in our system in January on the bottom left. And over time, they went into the doctor's office apparently in March, and something happened, and there's a diagnosis that showed up. Some more things showed up in April. And as the year goes along, you can see that the number of HCCs is increasing. And then on January 1st, something magic happens. The blood sugar becomes normal. The amputation grows back. The dialysis isn't needed. The patient's kidneys are working again. And you need to start all over. And this is where there's a conundrum for outpatient CDI, because you can't query the doctor on January 2nd to say, hey, is the patient still on dialysis? Hey, do they still have diabetes? You can only do it from a face-to-face visit. And remember, you can only do it from today's encounter, and you can't really query in your query put all the stuff from previous outpatient visits. That's evolving. That's got to change. But what I wanted to focus on is the patient comes into a hospital, and you don't know what was happening on the left. All you know what's in the dark pink, and something happened during the hospitalization. By the way, you never want to be admitted to a teaching hospital on July 1st because that's the first day of internship, and that's among people in teaching institutions, you know to avoid that. So I picked a really bad month as an example here. But I don't know where we were on the y-axis, but I do know that the hospitalization added some HCCs, and I can look at the difference. So that's what I'm going to do in the next couple of slides. This one, I need to linger on this. We looked at hundreds of thousands of admissions and calculated their RAF score. And on the x-axis is what happened at baseline, what happened without CDI being involved. And on the y-axis is what happened because CDI queried and changed things. And things that are above the black line means that the RAF score went up as a result of the CDI staff being involved and asking queries. And that one's a little hard to figure out how many dots there are, but this is a little better. We actually increased the RAF score 38% of the time with CDI. A lot of times we didn't change it because remember, inpatient acute problems may not be reflected in the outpatient, but almost 40% of the time what happened on the inpatient side did impact the RAF score. I had to study this one for a long time before I could confirm what I already suspected, that the RAF score doesn't correlate with the DRG weight. They're measuring different things. The DRG weight is measuring inpatient acute conditions, whereas the RAF score is measuring the chronic conditions. So again, so you have it in your handout, I just took the top 20 inpatient HCCs that we see. Many of them are cardiac, no surprise, and congestive heart failure, the most common inpatient HCC. To me, that's no surprise. The bottom 20 HCCs, interesting, but it's a select population. Of course, there's not going to be a lot of proliferative diabetic retinopathy as a cause for inpatient admission. So that's interesting, but this may be the most interesting slide of all for those of you who are doing HCC work. These are the top 25 diagnoses that drove large shifts in the RAF score. So documenting metastases, secondary malignant neoplasms, that one surprised me. The next one, the pressure ulcers, stage 3 and 4, also surprised me a little bit. I knew they were important, but they're a huge driver for RAF shifts. So if you're trying to figure out some things to focus on, because HCCs and RAFs are just too big, this would be a list for you to study and start looking at. And also, it became really clear that we need to stamp out the unspecified codes. Well, you need to do that on the inpatient side as well, but for the outpatient work, that is also extremely important. So anytime you have an unspecified code, you should be querying to try and get it more specific. And I obviously couldn't list them all on the slides, but Hodgkin's lymphoma unspecified, you don't want to be coding from that. There's 63 more specific codes there. Acute MI, there's 12 more specific codes, et cetera. So anytime you have an unspecified, and I think what we're going to see in the future is some report cards on physicians, and we're going to see a report card on Dr. Elian saying, well, what percentage of his outpatient charts are being coded with unspecifieds with a goal, because that's a nice key performance indicator. I can measure it. I can impact it. It does actually reflect our underlying processes and our business goals, because we really want to drive that down to zero. I suppose occasionally I might have something that I just can't specify further, but I think I am being sloppy if I've got a lot of charts with unspecified codes. So we're basically getting down to the end because the next thing you want to have, inpatient and outpatient, is some comprehensive reporting to be able to pull all this together. And I just put together two reports just very briefly. This one showing the RAF impact. This is similar to that slide that I had with a kajillion purple dots on it, but showing the baseline and then current. Baseline is what happened without CDI involved. The current is either the final working or the coded set of diagnoses, and showing what the impact is. This is by month, and we can also show it by the clinical documentation specialist, just showing what that impact is. And remember that there's not always a denominator. There's not always an expected. If you're a CDS who's reviewing well baby deliveries, then there may not be much hope of increasing the RAF score. If you're posted on the burn unit, then you are going to have a major opportunity for improving this. So I apologize for speaking so quickly, but I'm repeating myself here, but I put so much of this into the handouts so that you would have that to refer back to, and just wanted to take our time to highlight just a few things. So I think to go outpatient, you should start inpatient. It's well defined. We know the workflows. We know how to do queries. You can get familiar with HCCs and RAF scores on the inpatient setting. They are important, and you can start stamping out the unspecifieds. Then when you're going outpatient, recognize the areas where it can be helpful, and try and limit it. Start small before you start trying to do it everywhere. Some issues may be hard. E&M coding is really, it's not impossible, but it's a little difficult to impact through the CDI workflow. Maybe that's not where you want to start. So start with a narrow focus and have good definitions of what you want to do. Figure out the clinics where you want to start, get some metrics, and look at staffing. You may be surprised at the adverse impact that it's going to have on staffing. People who are doing these, especially with HCCs, find that they're having to hire a lot of munchkins to sit and calculate the HCCs and the RAF scores. So this slide is one that's going to be closing most of my talks for quite some time. It's in honor of my late father, who was a consultant, and he used to say that we cannot reliably predict the future. Our job is to create it. So I'm going to leave this slide up on the screen, just reminding you how to get your CEU credits. It will also be in the handout, so you'll have it there. And I'll leave it up on the screen so you can write down the link while Karen feeds me some more questions.
Thank you. A couple of questions. One question about clarification about the RAF score. This person wants to know if the RAF score is cumulative for all HCC values a patient has.
Short answer, yes. You take the categories, you put them into a hierarchy, and you add them up. Now, there's some exclusions and there's some ways to interact it. You don't just take the score for a given HCC and add them all up, but in essence, they are cumulative.
Great, thank you. Here's an interesting question about the future. I know we might want to get your crystal ball out again there. The question is, do you think that artificial intelligence will eventually take over coding completely? And is there a future for medical coders who have just gotten into the field? Interesting.
Artificial intelligence is not a substitute for natural intelligence. And I've been in the field of computer science, as I mentioned, since 1968 or 1969. I don't think yet computers have clinical judgment. I have a big problem with a computer reviewing a chart and then sending out a query. You're ethically only supposed to query on things that are clinically relevant, and I don't think a computer can determine that. Now, that having been said, there are some very interesting experiments where I know one company that is claiming that they are kind of an autonomous encoder, and that they can take the chart with and generate 100% accurate or complete set of codes. Very interesting claim. I don't know what the denominator is. And I think a computer that can exhaustively look at every last little thing may be better than a bad coder. But I can't imagine that they're better than a good coder. I'd much rather think of it. There's something called CAD, computer-assisted diagnosis. I think I've got that right. And CAD is used, for example, in mammography, where it will pre-screen, the computer pre-screens the mammogram and will highlight areas and little specules of calcium. And there it's been shown that if you are a good reader and you read with CAD pre-reading it for you, it takes a good reader and makes them better. It really cannot take a bad reader and make them good. So I don't think there's a substitute for common sense. I think we all have jobs in the future. Yes, I think computers have a role, but I think coders will have some job security for quite some time.
That sounds like a good answer. I like that one. I have time for one more question, and that is about the unspecified codes. And this person wants to know if you think the unspecified codes are due to the provider's lack of coding education, or just truly they don't know how to specify a diagnosis, or maybe it's an EHR issue. What do you think about unspecified codes?
I think they don't know how to specify the diagnosis. Now, it was going to take more time than we have, but I lecture to doctors, write a hell of a note. Don't write an outpatient note that's different from an inpatient note. Don't write a Blue Cross note that's different from a Medicare note. And the doctors say, well, don't you know, Dr. Allian, if I put probable, then they can't code that on the outpatient, but they can code that on the inpatient. And my answer is, you've got coding professionals all around you. Let them do their job. You do yours. Your job is to make the most complete assessment and documentation of that you can. And they may not understand the specificity that's needed. Laterality, that's easy. Acuity, that's easy. But there's some of these that are more difficult. So, yeah, I think they just need an education because they don't always think the way coders do. That's no surprise. That's why there is the field of CDI. So I think doctors just need a continuing education effort about that. And I hope we're not to a point where doctors need to learn to be coders, because I think doctors are lousy coders.
Absolutely. Well, I think we're just about out of time. Thank you so much for this great information. Sharon, do you have a couple of things to finish up our presentation today?
Yes, just wanted to remind everybody that an email will be sent out tomorrow morning. That email will contain a link to the handouts as well as a link to this webinar recording, so that I've seen a few questions come in about accessing the recording. So that is forthcoming, and you'll also have a link to access your CEUs. And if you have any problems, just send me an email and we'll take care of you. Thanks everyone for attending, and thank you again, Dr. Allian, for a great presentation.